Hello, please subscribe and like for our channel. Thanks very much.
The next case is a case number 2 where you have a 90-year-old male that presents with a 2-day history of abdominal pain. The pain started at the central abdomen and has now become constant and has shifted to the right iliac fossa. The patient has vomited twice today and is off his food. His motion were loose today, but there is no associated rectal bleeding. Examination: the patient has a temperature of 37.8 degrees Celsius and a pulse of 110 beats per minute. On examination of his abdomen, he has localized tenderness and guarding in the right iliac fossa. So what are the questions? So the question is, what is the likely diagnosis? In this case, your likely diagnosis is acute appendicitis. Generally, acute appendicitis presents with a periumbilical pain or a central abdominal pain, and then later on it shifts to the right iliac fossa. And the reason why it shifts is because you have to know that at the beginning of the pain is periumbilical. The pain is periumbilical because all the pain of the midgut are going to be referred to the periumbilical region. All the pain of the midgut are going to be referred to the periumbilical region. All the pain of the foregut is referred to the epigastric region, and all the pain of the hindgut is referred to the hypogastric region. Is it clear? Now you need to know that what the midgut, the foregut, extends from the mouth to the proximal, is extended from the mouth to the proximal third of the second part of the duodenum. Is it clear? Now the midgut extends from the distal third of the second part of the duodenum till the proximal two-third of the transverse colon, while the hindgut extends from the distal 1/3 of the transverse colon till the anus. So most of the pain of the acute appendix is located now in the midgut. So that's why the pain starts at the periumbilical region. And now when you have inflammation of the appendix, you're not going to have the appendix touching the parietal peritoneum. That's why the pain now is going to change the site and is going to migrate to the right iliac fossa. Is it clear? So those are the different things you have to know. Now, what is the differential diagnosis? Your differential diagnosis of what are the differential diagnosis of right iliac fossa pain? You must know everything that is located in this case. In that case, now in this case, you have a man. Is it clear? So a man, you should not speak about things located in women like ectopic pregnancy. You should not think about Michtel's-Mark's disease. You should not think of ovarian torsion. You should not speak about all those things. Is it clear? It's a man. So in a man, you should speak about things like a 19-year-old male. So you can have merkel diverticulitis, as you have just seen in the initial question. Is it clear? So you have merkel diverticulitis. One, you can have anything inflamed at that level. Is it clear? You can have a urinary stone. So what are the structures located there? You have the ureter. Is it clear? You have the ureter. The pathology of the ureter can be what? It can be upper urinary tract infection. You can have a ureteric stone located at that level. Is it clear? At the level of the ureter. Now the next structure that can be located there, we have what? The next structure located there, we have the epididymitis. Not the epididymitis, but you have the vas deferens. Is it clear? That moves towards the right iliac fossa in order to drain into the prostate via the ejaculatory drop. Is it clear? So in a case where a patient has epididymoorchitis, is it clear? Epididymoorchitis can also get referred to the right iliac fossa, and then the patient has a pain there. Is it clear? So next structure that can be located there, we have the colon. In the case of the cecum, in the case of a typhlitis refers to the inflammation of the cecum. Is it clear? When you have typhlitis, when you have also ileitis, inflammation of the terminal ileum can result to that. Is it clear? So those are the different, you have also structures like in the mesenteric region, like mesenteric adenitis can result to right iliac fossa pain, mesenteric adenitis. Is it clear? So we have mesenteric ischemia that can result also at that right iliac fossa pain. So those are the different things. So you have to just know the structures and then the pathologies on the structure located on the right iliac fossa. How will you manage this pain? Is it clear? So in this case, you need to know how you manage the pain of a patient that has acute and how to manage the pain of a patient that has acute pain. So you need to know that you manage the pain based on the ladder scale. Is it clear? You manage his pain based on the ladder scales. Is it clear? Now, if the patient has a ladder 1 pain, you just use acetaminophen like paracetamol. If the patient has a ladder 2 pain, you use acetaminophen and steroids. Is it clear? And then if the patient has a ladder 3 pain, you use now opioid-like analgesics, and then you use non-steroidal anti-inflammatory drugs. So for if the patient has a ladder 2 pain, you use acetaminophen, non-steroidal anti-inflammatory drugs. And if a patient has a ladder 3 pain, you use now opioid-like drugs and opioids. That's how you manage the pain of the patient. Now the next question is, what complication of any surgical intervention that may be required? So what are the complications of surgical intervention that is done that can be required here? So the complications that somebody can have, you have to know that every time you want to speak about post-op complication, so you have post-op complication related to the pathologies, and you have general post-op complication. So when you want to speak about post-op complication, speak about post-op complication in 2 ways. You have post-op complication based on the pathologies, and you have general post-op complication. Now, post-op complication based on acute appendicitis. Post-op complication based on acute appendicitis, that's locally. You can have fistula formation, like in the case of fecal fistula formations. On acute appendicitis, you can have fistula formation. You can have abscesses. You can have abscess formation, like in the case of peritoneal abscess, pelvic abscess. You have subhepatic abscess. You have abscess formation as a post-operative complication that you can have. So those are the complications specific to acute appendicitis. You can have fistula formation, like fecal fistula. You can have abscess formation. You can have sinus formation. Those are the specific complications of the post-operative. Now, the general post-operative complication they can have can be divided into immediate, early, and late. Immediate, early, and late are the general complication. Among the immediate complications, you have post-operative hypoxia. Post-operative hypoxia can occur among the immediate complication. Like in the case of atelectasis, or when you have an aspiration, post-operative hypoxia. Now we have post-operative anesthetic-related complication. Post-operative anesthetic-related complication can cause in the case of anesthesia. When the patient has allergy to anesthesia and all those type of things, or a malignant hyperthermia as a result of the anesthesia. So that's a post-operative anesthetic complication. Now the third one is post-operative iatrogenic complication. Post-operative iatrogenic complication consists of any lesion to the organ as a result of the operation. Post-operative iatrogenic complication. Now the fourth one is post-operative hypovolemia or hypotension. So when you are doing operation or intraoperatively, you can do what? You can have a patient that has hypotension as a result of what? As a result of either hemorrhage. So that's post-operative hypotension can be associated with post-operative hemorrhage. So I'm associated with post-operative hemorrhage or a poor heart function. And when you have a poor cardiac output to sustain for the stress of the surgery. Now the next thing, you have also post-operative kidney failure. Post-operative kidney failure, that is also called post-operative anuria or post-operative oliguria. So all those are the immediate post-operative complication. Now, the early post-operative complications are what? You have post-operative fever. And now, in the post-operative fever, it's also called post-operative sepsis. And in post-operative sepsis, you have what? You have things like the 5 Ws, which are the causes of the post-operative sepsis. Among the causes of post-operative sepsis, the 5 W are, the first one is the wind. Is it clear? Meaning that what it is first the lungs that is going to cause fever within the 0 to 3 days. Fever is associated with pneumonia. So when you have pneumonia atelectasis, is mostly within the first 3 days, mostly pneumonia which they cause. So it's wind, water. Is it clear? Water now, urinary tract infection is going to occur between day 3 to day 5. Then we have wound or the surgical site infection is going to result to fever between day 5 to day 7. Then we have wonder. So we have wind, water, wound, wonder. Is it clear? Now we have wonder is for any other thing. We have wind, water, wound, walk. Like in the case of deep venous thrombosis. Deep venous thrombosis can also result to fever in between 7 to 10 days. Is it clear? And then the fifth one is wonder. Wonder is any other thing that can result to post-operative sepsis. Is it clear? Generally, the other occur after 10 days. Is it clear? Is it clear? Or it can occur before 3 days, like in the case of a malignant hyperthermia that occurs from anesthetic medication, but particularly propofol. Is it clear? Propofol. Is it clear? That anesthetic medication causes malignant hyperthermia. So those are the different things that you have to understand. Now, the next point that you have to note also so you have done already all the different post-operative complications. Is it clear? Now, the next complication that you have in the early stage, you have post-operative pain. Is it clear? You can have post-operative pain in the early stage. After post-operative pain that you have another post-operative complication in this period. So you have post-operative thrombosis. Is it clear? Is it clear? So those are the different post-operative complications that you have. Now, in the late post-operative complication, you have post-operative healing disorders like fistulas, like adhesion formation, like sinus formation, and all that. So those are the different post-operative complications that you can have. So from here, we'll say thank you, and don't forget to like and subscribe for our channel. Thanks very much.
Hello, purchase your book, medical book, health science book, physics book, computer science book, all from us on 652-659429, and please don't forget to like and subscribe for our 2 channels, Science Video Makers and SchrDbb. Let me say the number again: 65699429. That is the place where you're going to have all these books. As you can see, we have the computer science book, which is shown in this image. You can see this is all the example of the computer science book, all inside. You have all this. We have the medical book for the first year, second year, third year, all available with all the explanation and questions. We have the physical examination book with all the step-by-step physical examination. This is the workbook for medical third year. The workbook for medical third year. This is the first year workbook. This is the second year workbook. As you can see, this is the second year textbook. All this we have on the no contact 652-659429. Thanks very much.